Hi, I'm Harlan Krumholz, editor of JACC. We're focusing on obesity, and I'm here today with Ania Jastreboff, one of the world's leaders in obesity medicine, to talk about some aspects. Okay, Anya, my great colleague at Yale, here's some wisdom, right? A lot of cardiologists are just beginning to start to use these medications. You and I have talked at length about the importance of titrating up slowly in order to avoid the adverse effects, which can accrue because people just move too fast. Can you just give some quick hints? What are some special hints that you can share, secrets that you can share with cardiologists about the way to use these medications as they begin to integrate these into their practices?
Sure, it's my pleasure. And they're not secrets, they're all tools that we should be using. So the most important thing is to know that most of the side effects that occur are gastrointestinal, and they mainly occur during dose escalation. They're transient and during dose escalation. So that's key, because that during dose escalation tells us something. And what it tells us is that we can decrease the side effects by going up more slowly. So if you remember nothing else, it's start low and go slow. Always start with the lowest dose when you start one of these medications in a patient who's not taking one of these medications, who hasn't taken one of these medications previously, and then go up slowly. There's nothing that says you have to go up once a month. That is not a requirement. And most of my patients, we do not go up once a month. So, the parallel would be if you start someone on an antihypertensive, would you automatically always go to the highest dose, right? If they have, borderline hypertension, you're not going to use the highest dose. You're going to go up slowly and tailor it to what the patient needs. And it's the same thing for these medications. We need to start low, go slow, and tailor to the dose that the patient needs. So let me give you an example. So let's say that you have a patient and you start on one of these medications and they do okay with the first dose. And then, 6 or 8 weeks later, you go up to the second dose and now they're having nausea. Well, if that nausea is mild, you can see how they do for another, 4 to 8 weeks. If that nausea is moderate, go down on the dose. Let their body have extra time to adjust. If and when the nausea abates, then you go up on the dose. And basically, in this way, if you don't go up, if a patient is having nausea, they're not going to have vomiting. Vomiting occurs if we go up too quickly or if a patient starts on a higher dose inadvertently rather than on the lowest dose. So start low, go slow, and you do not have to go up once a month. Now, there are also mitigation strategies that our patients can employ. So we can help them by going up slowly. Our patients can help us with a few things. One, if a patient is having side effects, invite them to tell you about those side effects. So before they even start on the medicine, say, look, if you have side effects, come tell me. I'm not going to take the medicine away. We're going to work through it together. We're going to figure out how to help you. The next thing is they can do certain things in terms of their eating. So one, they can anticipate that they're going to get full earlier. So eating smaller amounts. The next thing is they can start to notice which foods may exacerbate their symptoms. So let's say that they eat egg salad, and every time they eat egg salad, they have diarrhea. So during the dose escalation, maybe eat less egg salad. It's high in fat, and maybe that's what is exacerbating their symptoms. And then the last thing is they may not be able to eat as much in any one sitting. So eating more frequently, but smaller amounts is also helpful. So again, those mitigation strategies for patients are not eating past the point of fullness, eating more frequently but smaller amounts, and then noticing which foods may exacerbate their symptoms. And I think if you implement the strategies of going up slowly, not once a month, but what the patient needs, and then having the patient implement some of those strategies and then let you know if they're having side effects, those things work really, really well. And patients really tolerate these medications very, very well clinically. In clinical trials, we go up as the trial says, right? They're protocolized. And that's because the FDA needs 52 weeks on the treatment dose. And so they have to dose escalate during a certain time period to be able to make sure that the FDA has the information that they need in these regulatory trials. But in clinical practice, just as we, don't dose escalate necessarily for other agents, within a certain calendar or a certain framing, in the same way, we can really tailor this to what the patient needs.
Is there any concern about malnutrition? People stop eating very much. Are you giving people vitamins or are you giving them any advice about their diets?
Yeah, so in terms of eating, and in terms of eating and physical activity, I'm so glad you asked about this. So first, I'll just say there's no medicine out there that we've created so far that can help people eat more healthfully or move more. That does not exist yet. Having said that, I think some of these medications down the road will figure out how they may affect food preference. We already know with these medications that during dose escalation, the foods that tend to cause more side effects are things like fatty foods. So people may prefer not to eat those during the weight reduction phase. Once they hit plateau, they're able to tolerate those foods much better. And we can talk about that too, because that's actually really important. So we can come back to that. In terms of recommendations that I give to patients when they start these medications, there's a couple of key things. The first thing is in terms of their eating, they are going to be eating less during the weight reduction phase. So prioritizing protein, and I usually recommend about 1 gram per kilogram of protein. Now, if you work with a dietitian, they can work with your patients on that. There's also many apps that your patients can use, like MyFitnessPal or other things that are free and can help track how much they're eating in terms of protein intake. So that's really helpful. So lean protein intake about 1 gram per kg for your patients. The second thing is I say prioritize fruits and vegetables as much as you can. And the reason I say this in terms of the protein and the veggies is because they're eating smaller amounts. So if they're eating smaller amounts, it's really important to eat those things first because they're going to get full and then they won't have room for that protein or those vegetables. And the third thing that I talk about in terms of eating, or actually more importantly, drinking, is to make sure to stay well hydrated. So especially as they are in the weight reduction phase, it's so key to focus in on that. We know that thirst can also decrease, just like hunger decreases during the weight reduction phase, so can thirst. And patients can become dehydrated, or if they're having diarrhea, then they can also become dehydrated. So it's really important for patients not only to drink a lot of water once a day, but to take sips of water throughout the day. You can't see my glass of water, but I always have a glass of water with me no matter what, just because our kidneys are important. So I always encourage my patients to drink a lot of water and to make sure they stay well hydrated. Now, physical activity, this is really key. It's really key for our patients to also add in physical activity or movement throughout their day, and especially resistance exercise. And there's been a lot out there about muscle mass and that people lose not only fat, but muscle. Well, that is the case with any treatment for obesity, whether that is bariatric surgery or diet and exercise or these medications. People lose both fat and muscle. There are medications in development that can target losing more fat mass while preserving lean mass, but right now we don't have those medications yet. They're in development. And I always recommend to my patients, whatever movement or whatever exercise you like during your day, whether it's taking walks or anything, just add in as much as you can and try and add in some resistance exercise any way that you can do that.
That's terrific. And just to get to your point about the goal or plateau phase, what do you do for goals?
Mm-hmm. So there's two questions in that. One is targets. So we don't have really great defined targets or goals in terms of obesity treatment. What is the goal of obesity treatment? It's not a BMI of 25. BMI is a screening tool, and we're using it as a diagnostic tool, but we're not including in that fat mass or percent fat mass or any other health measures for that person, whether it's blood pressure, A1C, lipids, other obesity-related diseases, symptoms of obesity that patients may have, such as a preoccupation with food, which we tend to call food noise. So we're not accounting for any of those. And I think targets and goals for obesity treatment will include that down the line. We're not there yet, but we're certainly working on it. Now, your question about plateau. So what happens when a patient starts one of these medications, if they're responding, they start to lose weight. And what we think is happening is that their defended fat mass, or how much energy their body wants to store, is re-regulated with these medications. And it's re-regulated to a new set point, a new place. So let's pretend that you have a patient who weighs 220 pounds and they start on a medication and they decrease their weight to, let's say, 200 pounds from that 220 pounds. So they lose 20 pounds and they hit a weight plateau. if you could increase the dose of that medicine to see if the weight is further decreased, and that's usually what we do, or sometimes we add another medication. But these phases of treatment are really important. So during the weight reduction phase, that's when patients are most likely to have little food intake, because the way that I say it is that they're chasing a new defended fat mass. So as soon as they start a medicine, as soon as they start a dose, they're chasing a lower defended fat mass. And every time you increase the dose, they're chasing a new lower defended fat mass. So during that weight reduction phase, their appetite is decreased. Once a patient reaches plateau, a weight plateau, or a defended fat mass plateau, their appetite and even their cravings return, but the weight does not, as long as they continue the therapy. So this is really important for patients, because sometimes they may start a medicine and say, well, I don't really want to eat food. Like, I don't enjoy food. It's just kind of there on my plate. I could take it or leave it. It's not negative, but it's also not something positive. And it's just kind of there. And they eat a few bites of food and they're full. You want to reassure your patients. You want to reassure them that once they reach plateau, they will have cravings again. They will have hunger again, and they will have that return of enjoyment of food that they may have lost during that weight reduction phase. They'll also have the ability to eat more food. So again, during the weight reduction phase, they're eating very little. They're chasing that new defended fat mass. Once they reach plateau, their body's like, oh, I'm good. I'm where I need to be. This is exactly how much energy I should carry. So some days I can eat more and some days I'll eat less, and that's fine. So you just need to reassure your patients that it's a journey and it will change over time. And you also need to let them know this, because some patients get anxious when they get hungry again. They get anxious when they have cravings again, because they get so worried that they're going to gain back the weight.
Yeah.
So you need to just reassure them that as long as they're taking the therapies, we're going to continue to make sure that they're doing well. And if they need additional therapies, we'll add them. If they're continuing to respond well, then we'll continue that therapy. And really that reassurance and knowing where the path will take them is really key.
And I think you're raising, as we get to the end, one other important issue, which is helping to build in the right expectations for patients. So this also goes with your start low and go slow, telling people we're really going to try to get to a destination over the next year or so. So don't expect that this is something we're going to give you and then you're going to get to, treat your obesity and have remarkable results in the short run. This is something we're committed to. It's a chronic condition. We're going to make progress over time, and you're going to go through various phases on this journey, and we're going to be working together on this. But don't think this is going to be like, I need 2 shots and I'm going to be, a better place. It really is a commitment. It's going to be interesting to see as these new meds come out once a month, oral, all the different kinds of meds with happens. But I think this is going to stay true no matter what comes out, which is start low, go slow, and building in the expectation that, we're going to try to be in a better place a year from now. And it's a journey, as you said.
Yeah. I completely agree with that. And I think, one of the things that helps is to say, well, the weight did not come on overnight. It took years. And so it's not going to take us years to help you, carry less weight, but it is going to take time. And that is not a bad thing. We want to do this carefully, safely. And to come back to one of your questions in terms of concern of patients not eating enough, if you do have a concern that your patient is not eating enough, because these medicines are going to get stronger and stronger and more powerful, is to say, okay, well, maybe I should decrease the dose.
Yeah.
So the way to do that is not to say eat more, because if you say to your patient, well, you need to eat more, they're going to have side effects. That's when they're going to feel nauseated. What you need to do is decrease the dose, and that allows your patient to potentially eat more food. And then you can always increase the dose. The other thing that we talk about, and we really need more data on this, we don't have data on this, is, what is a physiologic rate of weight reduction? So with bariatric surgery, we don't have the luxury of slowing down weight reduction. You have bariatric surgery and then you lose weight as you lose weight. With these medications, if we titrate more slowly, the weight reduction can be more slow. So right now, because we don't have data to inform this, I usually target no more than 1% per week of weight reduction. And so I just do a really quick rate calculation and see how they're doing. And if they're losing more than 1% a week, I don't increase the dose or I de-escalate the dose. And that ensures that our patients, can eat the amount of food or the amount of protein or veggies or anything that we would like them to eat, and then also potentially gives them enough energy so they can do things like exercise. So those are really, really important things, and I think we need more research to really investigate that.
And are you using vitamins?
So in terms of vitamins, with bariatric surgery, there's obviously a recommendation for vitamins. And the question there is, bariatric surgery, it's not all because it's malabsorptive. So I think we don't know yet with these medications if there will be micronutrient deficiencies. So I think we have to wait for that type of data.
And what are you doing? What are you doing now in practice?
In general, if a patient asks and they are interested in taking a multivitamin, absolutely. If I take a dietary history and I don't think they're getting enough calcium or vitamin D, so patients with obesity tend to have lower vitamin D levels. We live in the Northeast, so we don't get a whole lot of sun anyway, and we wear sunscreen, right? Because we don't want to have skin cancer. So a lot of patients are vitamin D deficient. So that, that's something that, again, in a multivitamin can help that. Our patients on metformin can have B12 deficiency. So I don't counsel against taking a multivitamin. I think we need more data to really know what's going on, but I don't counsel against it.
That's terrific. Thank you so much.
You're welcome.